done because the core pathologists think they're the only ones that can make the diagnosis on biopsy. Many sites have a pathologist who's not a renal pathologist. Many hospitals will have a general pathologist who knows renal pathology, but not to the level that a full-time renal pathologist who does nothing but renal pathology does. So it was essential that we have confirmation of the initial biopsy reading. What were some of the factors that would prevent a patient from being enrolled or considered in the trial? We had to be very careful here. We didn't want to exclude someone who might otherwise benefit from the trial. Well, if they had a condition called secondary FSGS, which was not touched on in great detail, but this would be someone who has FSGS associated with other conditions. They may have developed another glomerular disease or another systemic disease, and FSGS is found on biopsy. And that would rule them out from a primary FSGS standpoint. If the patient had received prior therapy with agents that were being considered for the trial, which in this case were cyclosporin or a close member of the same family of calcineurin inhibitors, tacrolimus or Prograf or FK506, they were clearly ineligible because they had already been treated with a test drug, or if they had been treated with the mycophenolate mofetil or Celsep, a test drug, that would exclude them from the trial. If they had had sirolimus or Imuran or azathioprine, they would also be out of the trial. So what does that really lead for someone who has a steroid-resistant nephrotic syndrome who may have received other therapies in terms of making them eligible for the study? Well, if they've received Cytoxan or chlorambucil, which you have heard earlier is a very popular treatment for steroid-resistant nephrotic syndrome in a child, then if they've received that therapy within 30 days and failed it, they can still be eligible for the trial. Less commonly used in the United States is an agent, an antiparasitic agent called levamisole, which is used in Europe quite frequently for steroid-resistant nephrotic syndrome. We can't get it here. And methotrexate is another agent that could have been used and would not exclude them from the trial. If the patient had uncontrolled hypertension, and we left the definition of uncontrolled hypertension to the clinician to determine how many drugs they may have put their patient on before they've come to the conclusion that it doesn't work. 3 agents, 4 agents. Clearly some patient who cannot have normalization of the blood pressure should not be enrolled in the study for a risk of worsening the hypertension when you put them on medicines that are known to cause an elevation in blood pressure. If they have diabetes mellitus type 1 or 2, that would exclude them. That's a different pathophysiology, although they do get a histologic lesion similar to FSGS, but it's associated with diabetes. If they've had an organ transplant of any kind, they would be ineligible. And if they were obese. Initially, when we put this exclusion criteria in, we didn't realize the impact on the population that we were screening. But I will tell you, after 3 years of the trial, we're surprised at the number of patients who are excluded from the trial because of their pre-treatment weight or BMI being greater than the 97th percentile for children between the age of 2 and 20, or greater than 40 BMI if they are an adult, greater than 21 years of age up to 40. We all know this, we're in the midst of an epidemic, and this epidemic is affecting our children as well, and we have a lot of patients that are not eligible for the trial who were deemed obese even before they received their initial course of steroids. This is a scheme that kind of gives you an idea how we developed the treatment rationale and the treatment arms for the trial. I'll go into detail about each drug afterwards, but we have a patient who's randomized, which means that the number goes in a hat, patient's number goes in a hat, and it's determined and randomized which arm of therapy they go into. We cannot determine beforehand what they're going to get, but we do know what they're going to get after they're randomized. We know which patient gets treated with a cyclosporin treatment and which patient will be getting treatment with Celsep and some dexamethasone. And they'll be treated with this regimen for 6 months. And at the end of 6 months, if they have failed treatment, which means that they have not responded in terms of the proteinuria, their proteinuria has not diminished to greater than 50% of what it was at the onset of the trial, or they have not gone into remission, they're considered a treatment failure. And then the primary clinician can give the patient whatever medication he or she feels they want to give. However, the patient remains in the trial in that we're able to follow them for the next 12 months and obtain data from them. If they've responded to the therapy by dropping the proteinuria to greater than 50% of what it was at baseline, or they're in remission, they continue on the therapy for 1 year total. At the end of 12 months, they're then withdrawn from the treatment that they've been assigned, whether it was cyclosporin or myclophenolate and dexamethasone, and they're followed for 6 months thereafter, and they remain on medications for their blood pressure, for their lipids, and they remain on the angiotensin-converting enzyme inhibitor that they were started on at the beginning of the trial, or they remain on an angiotensin receptor blocker for the following 6 months. And during that period of time, we're following their status to see if they have remained in remission and done so well after withdrawal of treatment. So we will be getting secondary outcome assessment as well in terms of who stays in remission or who relapses. And we will also be following things like growth and development, quality of life, and obtaining samples, which are critically important for this biorepository I'll talk about in a minute. So it's really 18 months in a study. If you're fortunate to respond, you're receiving 12 months of treatment and then a follow-up for 6 months. If you don't respond after 6 months of treatment, you still stay in the trial. You can be treated with other agents, but at least we're obtaining information. What are the therapies? What's common to both arms? The patient has already been deemed steroid resistant. Nobody wanted to continue therapy with high-dose steroids. So what was decided was that a low-dose prednisone or prednisolone would be given for 6 months in the initial time at 0.3 milligrams per kilo per dose for a maximum dose of 15 milligrams every other day. This is far below what the patient has been on during that initial month of treatment when they failed steroids, usually at a dose of prednisone around 2 milligrams per kilo per day. So this is quite low. It's still prednisone therapy, but it's alternate day. So the side effects are much, much less. And we are concerned about the steroid side effects, as you know. In addition to that therapy with prednisone, the patient will either take an angiotensin-converting enzyme inhibitor, lisinopril, or an angiotensin receptor blocker called losartan for the entire 18-month period. This will be done whether they have hypertension or not. The rationale for this treatment is that there is some evidence, there's enough clinical evidence and certainly experimental evidence to suggest that this class of renin-angiotensin blockers may be protective of the kidney through mechanisms that we haven't quite identified yet, but suffice it to say that they may protect structurally important cells that Dr. Holtzman will talk about later called the podocytes, and may prevent also deposition or scarring within the kidney. So it was felt that we needed to offer them this as well. And the dosing is based on their weight and their tolerance. There's a run-in period where low doses are started. They're carefully monitored for their blood pressure, for side effects of these agents on their kidney function, for development of high potassium in the blood, or other side effects related to these agents, which can be an allergic reaction or coughing. And they're very carefully titrated over 6 to 12 weeks before their maximum dose is achieved. The arms. The first arm is the standard of care. When we reviewed the world's literature and the meta-analyses done on experimental clinical trials or clinical treatment, there's only a handful of randomized controlled trials. And that term, randomized controlled trials, RCT, you should remember. That means that there's been a scientific basis for what we give a patient. And they're randomly assigned, they're controlled, and they're evaluated strictly. That's what this study is doing. It's a randomized controlled trial. And when we reviewed the world's literature, we found that cyclosporin is the first drug of choice around the world in pediatric nephrology for primary FSGS. There had been several studies done in the United States showing efficacy of this therapy as well in some of the patients, and the percentages vary with the study, but certainly the feeling of the group was that this is worth an effort as a standard of care. And the dose is 5 to 6 milligrams per kilo per day, twice a day. It's very carefully started and titrated over the course of 6 or 12 weeks to reach a level in the blood, fasting level of 100 to 250 milligrams percent. And that's the standard therapy arm. In order to achieve any scientific meaning from this randomized controlled trial, you have to have a standard of care. This is the standard of care. At least it was as of 3 years ago. The experimental arm, you have to compare that to the standard of care arm, involved looking at some novel agents that at the time there was some evidence that there may be efficacy in their use in certain glomerular disorders. And again, we took into account not only the data that was coming out, but also the safety data. One of the agents that was being used and is still being used and studied and formed the basis for this experimental arm is an agent called CellCept, or mycophenolate mofetil. It's a purine synthetase inhibitor. It's a stronger version of an older agent that's been around for a long time, an antimetabolite called azathioprine. Some of you may know it as Imuran, but it's stronger and more effective. And the dosing was 25 to 36 milligrams per kilo per day, going up to a maximum dose at 2 grams a day. In addition, it was felt that there was evidence from several clinical trials and clinical studies and reports in pediatrics that pulse steroids in patients with FSGS may be efficacious. And we looked at the data. There was at least 3 reports from the United States, 2 from in California and 1 from Alabama, that evaluated this. Granted that there were not a lot of patients in each study, but everyone seemed to have some anecdotal results that indeed in some patients who are steroid resistant with FSGS, if you give them pulse steroids, you can induce a remission. Some of those patients receive Cytoxan at the same time as the pulse steroids, and again, there were no randomized controlled trials. It was felt that based on that data and some data that was coming out of the NIH from a Dr. Kopp's experience with adults with varying glomerular disorders, that an oral version of a pulse steroids might be efficacious. And he had shown some data that dexamethasone, which is a high-dose form of steroids, given safely to patients in adults with varying glomerular disorders, had minimal side effects and was achieving some remissions in these patients. Based on that data, based on the data that intravenous pulse methylprednisolone might be helpful, we came to a consensus that we would give the patient a treatment with dexamethasone, an oral agent, along with the alternate day low-dose prednisone, for a total of 46 doses. And this would be a tapering dose over time, as you can see. Again, the safety data suggested that this had minimal side effects and did not cause worsening hypertension or bone disease or cushingoid facies. And here's just a review based on Dr. Kopp's data with 14 patients with FSGS. These are adult patients studied at the NIH who received these oral pulses, 4 days over then 28 days for a total of 8 doses, 8 months, I'm sorry. And you can see here that they didn't find any increase in cushingoid facies, no change in the pressures within the eyes, no new cataracts, no development of hyperglycemia. They didn't become what we call adrenal suppressed. They maintained their ability to make glucocorticoids. They didn't have any adverse changes in the psychological testing, and they had no changes in their hips in terms of avascular necrosis, which, as you know, is one of the things we worry about with prolonged steroid use. What were the outcomes, and what are the outcomes that we decided would be important to assess from this trial? A primary outcome is the attainment of a partial or complete remission at 6 months of treatment.